to share my screen now in a second. Just a moment, please. Okay, so I think you all can see my screen now. So before we begin, I'll just introduce the topic as well as about our pain school. So please type yes in the chat box if you all can see full screen. So this is about the 71st Pain Journal Club, and today the theme is MSK Ultrasound. We're continuing with the same topic, and we are focusing today on acute pain diagnosis. And we have with us esteemed faculties, Dr. Babita Ghai, Dr. Sandeep Sahu sir, as well as we have speakers, Dr. Neel OKA and Dr. Akhil Bhalla. So I will introduce the faculties later on. Before we begin, as is customary, we just go through the basic introduction. Pain medicine world over has got diverse issues and variable standards. There are different learning requirements and different offerings. Money and time is something which usually prevents physicians from understanding about this subject. Mumbai Pain School is an initiative of Benesha Spine Wellness and Pain Relief Center in Mumbai, and we focused on the online mode of education and focusing on mediums like Facebook, Instagram, X, or rather that time it was Twitter, and we focus mainly on the online learning, on-demand content. Most of our content is free for everyone, and we have some paid content as well. We conduct hands-on workshops. We are very fortunate to have been blessed with expert faculties. We've received their support from all over the world. It is said that the best teachers, they teach from the heart and not from the book. Journal Club is nothing, it's just a club. With the difference between a club and this, that instead of the music and entertainment, we focus on critical evaluation of recent academic literature, which is based on a defined subject. We value attendee participation. So I request all of you to be very vocal. You start with chat and we can just unmute you. You can speak and we can discuss anything related to the paper as well as the topic. So please be forthcoming. It is very tough to be regular. Today also I can see, in both online and offline, we have got different attendees most of the times. So try to be regular and you'll gain out the most. Journal clubs are very important. Even Harrison used to hold his journal clubs twice a month with critical evaluation as of the literature as the sole objective. We request the participants, the speakers especially, to stick to the time allotted, and as discipline is extremely important for the success of the program. And last but not the least, healthy skepticism or praise is most welcome. So guys, please just type in whatever you feel like, and we'll go a bit about everything. So now I will request the speakers to start sharing their screen and just put up their presentations. Dr. Akhil, you are going first. So can I see your presentation, and please put up your CV. So Dr. Akhil Bhalla has done his MBBS, MD, fellowship in pain management, and also FIAPM. And he's currently working as assistant professor and in charge of pain medicine at the Department of Anesthesia and Pain Medicine, Adesh Medical College, Ambala. He's a founder and consultant of Pinnacle Advanced Pain Management at Chandigarh. He's also visiting interventional pain consultant at multiple hospitals in Chandigarh. So over to you, Dr. Akhil, for the first presentation.
Thank you, sir.
Siddharth starts. Before Akhil starts, just one thing is for the delegates is that Siddharth this time has picked up a very, very extremely relevant topic. We have he's made this role of ultrasound so important that now he's picking up if you would have gone through both the articles, these are the spot diagnosis like the focus we do, and these are the role of ultrasound in the emergency department wherein we as pain physicians are involved. So first Akhil is going to start on the spot diagnosis, or you are talking about the emergency?
Emergency one, I think.
Emergency one.
Yeah.
Yes.
So over to you, Akhil, now. Thank you, ma'am, for the kind
Thank you, ma'am.
introduction. I can't see Sahu sir. Let me check if he can add something. Okay, I'll just call him. Maybe some trouble logging. Okay, Akhil, you start with it, and we'll introduce both the faculties in a while once you're done, guys. Okay.
Sure. Good evening, everybody. So the first article that we'll be discussing in this journal club would be the musculoskeletal ultrasound in the emergency department. So this article was a narrative review, and it was published in the Seminars in Musculoskeletal Radiology Journal 2020. It was conducted by Vito Cianca et al. And it was conducted in the IRCC Institute of Orthopedic Disease, Milano, Italy, in the Department of Diagnostic Imaging, Pignata Grand Hospital, Italy, and the Department of Medicine and Health Sciences, University Molise, Italy. So the introduction, role of musculoskeletal ultrasound in the emergency setting is useful not only for an early diagnosis, but also for intervention procedures that can be done right there. The main advantage being rapid evaluation of symptoms at the bedside with both a static as well as a dynamic assessment, which is useful for the diagnosis of pathologies related to skin and subcutaneous tissues, muscles, ligaments and tendons, bones and nerves, which all covers the musculoskeletal system, which all will be discussed in the paper. So this article reviews all of these musculoskeletal pathologies, focusing on the main findings and which might influence the medical decision regarding the patient as when being presented in the emergency department. So for skin and subcutaneous tissues, the most common skin and subcutaneous soft tissue infections that is encountered in the ED is the abscess and cellulitis. And usually the pathogens which are involved are the Staphylococcus aureus and Streptococcus, amongst many others. Mostly these are involved. Ultrasound may show signs and findings of inflammation, such as fluid collection, edema, or a soft tissue stranding. Cellulitis is the most common form of a soft tissue infection, which is confined within the subcutaneous compartment. On a clinical diagnosis, it presents as a fever and leukocytosis, and also with a painful and a swollen erythema in the affected area. On an ultrasound, it would be a non-specific finding of edema and inflammation in the skin and the soft tissue. So the most common finding in this would be a cobblestoning appearance, that is a fluid fill area which separate the soft tissue and fat in a stripy morphology. On a color or a Doppler, you can see hyperemia of the infected area. So a severe uncommon form of cellulitis would be necrotizing fasciitis, and the patient usually presents with rapid clinical deterioration with significant morbidity and mortality. And the necrosis which occurs is due to microcirculation thrombosis and consequent ischemia in such patients. On an ultrasound, subcutaneous thickening with perifascial hypoechoic fluid and air when necrotizing fasciitis is concerned is present. So for an abscess, what is an abscess? It is a muscular or subcutaneous collection of necrotic and infective tissue with bacteria, inflammatory exudate, and molymorph. On an ultrasound, you can see varied echogenicities, which would vary from hypo, iso, or even hyperechoic at times, with an irregular wall thickness and a typical posterior acoustic reflection. This would not be diagnostic. But on a color Doppler, you can again see variable grades of hyperemia of the vessel abscess wall and the surrounding tissues. Coming to hematomas. So ultrasound varies, the findings of an ultrasound vary with the timing of which an hematoma presents. So it could be a hyperacute or an acute hematoma, a subacute or a chronic one. Hyperacute or acute, the hematoma would look like an anechoic or a slightly hypoechoic lesion with an increased enhancement of the echoes behind the lesion indicated presence of a liquid blood there. Whereas a subacute hematoma becomes more complex because there is now mixed hemoglobin present inside, which indicates a blood clot formation, and it is well loculated as you can see in the image provided. So this was a soft tissue hematoma of the knee, and it was well loculated, whereas there was also a posterior dislocation of the patellar tendon, which you can see in the image. Then comes chronic hematomas, which are formed like a solid structure and different echogenicity due to different products of the hemoglobin, that is now ferritin and hemocytrin are there, and calcification, or they even may become anechoic again, which gives you a sign of liquefaction that is present when there is a chronic hematoma. So for findings of ligament strains and tears, which is again a common pathology encountered in the emergency department, you can see a ruptured anterior talofibular ligament. This is the ruptured anterior talofibular ligament. This is the talus, and this would be the fibula. And you can see the undefined ligament which is present here. This would be the ruptured ligament. Again, you can see some fluid around, which would be because of the pathology. Then this image on the right shows a inhomogeneous hematoma. This entire thing is a inhomogeneous hematoma. And this would be the ligament which is torn with fibrin debris coming inside the torn ligament. So coming to foreign bodies. If you would look at the rate, a rate of around 38% of retained foreign bodies were overlooked at an initial clinical as well as radiological examination in the ED. The most common type of foreign bodies would be metal, glass, or wood or plant splinter, which may lead to inflammation or infective complications. Radiographs are able to depict 80% of the foreign bodies, but the radiolucent types remain undetected. So, which is not undetected on an ultrasound. Hence, it becomes imperative to do an ultrasound. USG offers a sensitivity of 87% and a specificity of 94%. Sensitivity ranging from 87 to 94% and a specificity of 97 to 99% in the detection of foreign bodies, which is quite high. Inflammatory reactions produce a typical hypoechoic rim around the foreign body if present in the soft tissue of for around more than 24 hours. However, high false positive results can be there because of calcification, scar tissue, air trapped in the soft tissue, or and so correlation with, of course, within a radiograph is always recommended. So coming to the foreign bodies, the images provided by the authors in this article, the X-ray film shows a small foreign metallic body in the soft tissue in the second metacarpal joint, which is better depicted on the ultrasound. You can see a huge body here, which is very clearly seen on an ultrasound. Again, for a fracture, again, ultrasound is very helpful. This X-ray image shows a radiolucent question mark in the sesamoid bone on the fifth metacarpal carpophalangeal joint. And on the ultrasound, you can see a fracture rim of the sesamoid bone, which is quite clearly visible on an ultrasound. Rib fractures can be very helpful. Ultrasound can be very helpful to diagnose rib fractures. On an X-ray, you cannot see a rib in its entirety, or maybe even a partial fracture could not be ruled out. So this was an X-ray film which was taken, and it was obviously unremarkable. You cannot see any fracture on the rib here. And apparently the patient had just had an intense bout of cough, and on an ultrasound, whereas you can see a tiny infarction of the seventh rib, which you may not be able to rule out on an X-ray. So for fractures, the typical finding would be interruption of the hyperechoic cortical line as was seen. May or may not have an hematoma or a soft tissue swelling around it, but usually a soft tissue swelling is there, which would be observed as an indirect evidence near the fracture. So the unusual use of ultrasound would be bone realignment. So you can do this especially for pediatric fractures, where you can see the bone, the fracture being reduced under ultrasound. And it was demonstrated that a bedside USG guided reduction of a closed forearm fracture in the pediatric population is very safe and effective and very helpful. In fact, you would need less of radiation. Real-time visualization of the entity of bone reduction with a lower sedation and fewer operative attempts is required if you do that. So coming to muscle and tendon injury, in most cases, the most common injured preferential site of tearing would be the myotendinous junction. On an ultrasound, this image was provided of the EHL or the extensor hallucis longus, and you can clearly see the tendon tear after a cut injury, and the detected tendon stumps can be seen, detached tendon stumps can be seen, and the interposed fluid gap can be seen in the tendon. Coming to muscle lesions. So there are intrinsic muscle lesions, that is muscle strain, which is during the eccentric phase, in which the force of active contraction is added to the stretching force applied to the myotendinous junction. Again, there are grades which is based on the ultrasound appearance, that is mild, moderate, and severe injury, grade 1, 2, and 3. In grade 1, you will have negative or ill-defined areas of increased echogenicity or fiber disruption with less than 5% of the cross-section area of the muscle. Grade 2, more than 5% area of the cross-section muscle, and the USG shows fiber disruption and discontinuity in the perimysium. Whereas grade 3 would be complete rupture of the fibers with associated hematoma. it is usually clinically evident with a palpable gap between the retracted stump when the patient presents with a grade 3. It is important to note that perifascical fluid detection is an unspecific finding and can occur in any of these grades. So it is not diagnostic of which grade the tear has happened. So this was the example of intrinsic muscle injury. So these were short axis and long axis scan for an intramuscular hematoma of the vastus intermedius. And it clearly shows the hematoma inside the muscle. And this was the longitudinal view. You can see in the longitudinal view also, you can see the hematoma quite clearly. So for muscle herniations also, ultrasound is a very significant diagnostic modality. This was the image which was provided by the authors, and on a longitudinal scan, you can see the tibialis anterior muscle, and this muscle was herniated from. You can see discontinuity here, and the aspect sign shows the bulge of the belly of the muscle, which you can see on the image provided on the right. So there was a bulge on the anterolateral leg, which was a bulge due to a tear of the tibialis anterior muscle. So coming to calcific tendinopathy. Now this is something which is most commonly presented by women in the age of more than 50 years having rotator cuff tendon tears. And rotator cuff tendons are involved in the tendinopathy. Features would be they would either be totally asymptomatic or may present with chronic mild pain as they usually do in the OPD, or when they present in the ED, they would present as an unbearable pain, and which is usually non-responsive to the common painkillers, which you could see. On an X-ray of the shoulder, the presence of a subacromial radio-opaque calcific deposit can be seen typically. So in some cases, calcifications are fluid and which are not easily detected on a radiograph. Here, the ultrasound becomes imperative. So ultrasound is very effective to detect a calcific deposit in the rotator cuff tendons or even in the bursa. On an intervention, ultrasound-guided percutaneous irrigation of the calcific tendinopathy is very effective to remove calcium and promote pain relief in such patients. Coming to peripheral nerve injury. So the Sedon's classification divided peripheral nerve injury into three, that is neuropraxia, actinotomesis, and neurotomesis. So the neurotomesis being the most severe kind, and in neurotomesis is where the ultrasound would be helpful. You can assay a gap length between the fibers, and an appropriate graft repair planning can be done by the surgical team later. So an important thing to note is both neuropraxia as well as actinotomesis can show loss of the honeycomb appearance, but as they will not show the difference of the gap length between the fibers, it is not diagnostic, and you cannot differentiate exactly between neuropraxia and actinotomesis. And again, they will also show a cross-sectional area increase of the nerve. So this image was provided. This was the fibers of the accessory spinal nerve, and this was the lesion here. This was the foreign body that was detected, and you can see the tearing or the playing apart with the gap length of the accessory spinal nerve. So coming to the critical analysis of the paper. So according to me, it was a very comprehensive review of the use of ultrasound to identify musculoskeletal conditions in the emergency department as the patients present. That being said, the interventional methods which are used to treat such MSK conditions were not analyzed in this article, and it could be might as well be done when you are actually going for a diagnosis. And use of musculoskeletal ultrasound should become a norm for these conditions which are being discussed in this article, because the musculoskeletal conditions presenting are very easily treatable, and this will facilitate an early diagnosis with prompt intervention right there in the ED. I think the take-home message would be that MSK is very essential in the ED, not only as a diagnostic tool but also as a guide for intervention procedures. Identification of a variety of pathologies is very helpful by an ultrasound, which can also be used to devise a treatment plan later. Thank you.
Thank you, Dr. Akhil. We'll take both the questions in the end. I think we'll combine them. With your permission, Babita ma'am and Sandeep Sahu sir. Sandeep Sahu sir is also here now. So I'll request Dr. Neel to please start the sharing his screen. Dr. Neel, please start sharing your screen.
Yes, sir.
Now. Yeah, so Dr. Neel OKA has done his MD and DNB in anesthesiology. Is from Dr. VM GMC Solapur, Maharashtra. He's currently a fellow in pain medicine at DYPU University in Mumbai. So over to you, Dr. Neel. Please continue.
Good evening, everybody. Today I'll be presenting this paper, which is the beauty of musculoskeletal ultrasound spot diagnosis. This was published in ROFO journal on May 2023 edition, which study was done by Elena et al. And it was done in Department of Anatomy, University of Crete School of Medicine in Greece, and Department of MSK Imaging, Diagnostic and Interventional Ultrasound Practice in Greece. So introduction. Ultrasound is a useful technique in musculoskeletal imaging, and it can be primary diagnostic imaging modality in many specific clinical settings. The advantages of ultrasound are well known and include real-time static and dynamic multiplanar image and lack of radiation. The cases were collected and selected by members of the Educational Committee of the ESSR. These will be 16 case scenarios, which will go one by one. The spot diagnosis first. 34-year-old woman presented with acute onset severe pain at the shoulder, which is radiating to arm, and there is total restriction of shoulder movement. The ultrasound showed this picture, and this is the overlying fat. This is the muscle, which is the deltoid. These are the fibers of deltoid. This is the greater tubercle, and this is the tendon. The ultrasonography findings were there was presence of mildly echogenic faint material in the supraspinatus tendon, and there was also edema of the tendon and thickening of the subacromial subdeltoid bursa. So they come to a spot diagnosis of it is acute calcific tendinopathy in the supraspinatus tendon. The rotator cuff calcific tendinopathy is a very common condition, and it is caused by presence of calcific deposits in the rotator cuff. The spot diagnosis 2. A 60-year-old woman who is manual worker came with 2-month-long shoulder pain and a limited range of shoulder motion that she is not able to abduct the arm. On the ultrasound image, this image shows this is the greater tubercle. This is the supraspinatus tendon. These are the overlying muscle fibers of deltoid. And this asterisk, it shows the hypoechoic fluid-filled gap in the tendon fibers. And the gap is extending from the inferior articular to the superior bursal surface of the supraspinatus. So the spot diagnosis would be, this is a full thickness supraspinatus tendon tear. And such tendon tears usually progress and enlarge over time with worsening of pain and associated with tear progression. A 32-year-old man who had tenderness and pain at the lateral epicondyle, which worsened with forearm activity, and his grip strength has gradually reduced. On the ultrasonography, he shows the power Doppler of the lateral epicondyle shows there is presence of neovascularity, and there is hypoechoic thickened area in the common extensor tendon. This is the lateral epicondyle, this is the radius, and this is common extensor origin. So the spot diagnosis would be, this is a case of lateral epicondylitis, and the lack of both neovascularity and grayscale changes in ultrasound has a high negative predictive value, and therefore suggest other causes of lateral elbow pain. And the fourth case, a 55-year-old man who, while abruptly lifting a heavy weight at work, he experienced sudden painful pop, which was associated with considerable pain, swelling, and weakness at the elbow. So the scan of the elbow in this person in axial plane, it shows a hypoechoic area in the distal biceps brachii muscle, which is surrounded by a hematoma. This is the supinator muscle. This is the overlying fat. This is the humerus, and this is the radius. And in the longitudinal plane, in the same case, it shows there is loss of delineation of the distal biceps tendon, and there is shadowing due to anisotropy artifact in the area of retracted tendon fibers. So this history and ultrasonography examination, which points towards this is a distal biceps tendon rupture. A 75-year-old woman who had a painful right wrist, she underwent the ultrasonography of the right wrist in the first extensor compartment, which shows a power Doppler shows increased neovascularity of the retinaculum, and there is marked thickening and hypoechogeneity of the first extensor compartment. And there is an increased volume of tendon, that is, there are edematous changes in this confined space. So this points to the diagnosis of this is a de Quervain's disease. Next spot diagnosis. A 35-year-old woman who had pain at the dorsal wrist and a mild decrease in the grip strength. She presented with this ultrasonographic finding. which shows there is a presence of a small cystic lesion, which is extending from the wrist joint and which has a short neck. So this is probably a dorsal wrist ganglion, and the ganglion cysts are most common soft tissue tumors of the hand, and majority are located in the area of wrist and communicate with the adjacent joint via a short pedicle. Next spot diagnosis. A 67-year-old woman who had blockage of her right ring finger when it was flexed, and it is painful snapping when it is extended. So the ultrasonography of this shows there is an irregular thickening of the A1 pulley at the level of metacarpophalangeal joint. This is the metacarpal, this is the proximal phalanx, and here is the irregular thickening, and there is also blocking of flexor tendon during flexion and extension, which is leading to formation of a nodule. So the spot diagnosis was this is a case of trigger finger, and ultrasound may also contribute to treatment of trigger finger when performing injections of steroid or release of the A1 pulley under the ultrasound guidance. And the next spot diagnosis, there was a 50-year-old woman who had focal pain on the right side of chest since approximately 1 month. The ultrasonography of the area shows there is a cortical irregularity of the hypoechoic cortical line of the rib, and there is slight elevation of the overlying soft tissue. So this was a case of rib fracture. So next spot diagnosis, a 48-year-old male cyclist who had a painful right-sided perineal swelling. So the ultrasonography of this swelling, it shows a hypoechoic ill-defined mass in the subcutaneous tissue. So given the history and the sonographic finding, this is a Baker's nodule. Spot diagnosis 10. A 36-year-old male runner who had a focal pain on the lateral side of the left iliac crest. So the scan in this area, it shows a focal thickening and hypoechogeneity of the proximal iliotibial band. This is the iliac tubercle, this is the overlying muscle, this is the fat, and this is the focal thickening along with hypoechogeneity of the iliotibial band. So the diagnosis would be that it is a proximal iliotibial band syndrome. The proximal iliotibial band syndrome is a syndrome described in athletes characterized by isolated pain at the iliac tubercle or at inferior lip of the iliac crest. The next case scenario, a 35-year-old woman who has burning pain at the anterolateral side of the knee, and there is also tenderness. The ultrasonographic features show there is a thickening of iliotibial band, and there is a small fluid collection between the band and the lateral femoral condyle. So this is a case of distal iliotibial band friction syndrome. Next spot diagnosis, a 65-year-old woman who has pain and swelling at the posterior knee, which is radiating to the calf. The ultrasonography shows this is the medial femoral condyle, this is the medial belly of gastrocnemius, and it shows a cystic mass medial to the medial head of gastrocnemius muscle. So the spot diagnosis is this is a Baker's cyst, and unless this cystic mass lies between medial head of gastrocnemius and the semimembranosus tendon, the cystic lesion should not be diagnosed as a Baker's cyst. A 15-year-old male soccer player who had pain and tenderness at the tibial tuberosity along with a local swelling. The ultrasonography in this area, it shows there is irregularity of the ossification center of the tibial tuberosity. There is a thickened physeal cartilage. There is a detached bone, and there is neovascularity at the distal patellar tendon. So this is a diagnosis of a Osgood-Schlatter disease, which is common in young and athletes. Spot diagnosis 14. A 38-year-old man who had a focal swelling of his right lower leg. So the sonography in this area showed there is area of convex bulging of underlying muscle, and there is also a focal defect in the superficial muscle fascia. So this is a muscle hernia. A 36-year-old man who had intense heel pain and inability to walk, and one day ago while jogging, he suddenly felt a pop, which was followed by immediate sharp pain in the back of ankle and lower leg. So the ultrasonography shows there is a discontinuity in the Achilles tendon, and there is a hypoechoic gap which contains hematoma and tissue debris. So this is the Achilles tendon tear. And a 39-year-old woman who had a heel pain, which shows the thickening and hypoechogeneity in the posterior third of fascia plantaris, close to its insertion on the medial tubercle of the calcaneus. So the diagnosis is fasciitis plantaris. So these were the 16 spot diagnoses presented in this paper. And the conclusion would be the clinical history, location, and ultrasound appearance are the key to spot diagnosis when performing MSK USG. The critical analysis, which I feel is MSK ultrasound provides real-time dynamic imaging. And unlike static imaging modalities such as X-ray, MRI, MSK ultrasound allows for assessment of dynamic movements. And it can be performed at point of care, such as clinic or at the bedside. But the success of MSK ultrasound is operator dependent and it may be time consuming. So the take home message would be the MSK ultrasound's ability to assess dynamic function, guide procedures accurately, and can be utilized at point of care makes it a valuable tool for precise diagnosis and effective management for improved patient outcomes. Thank you.
Thank you, Dr. Neel. Let me share the presentation. So we come with. So let me introduce the faculties. Both the faculties are here now. This is about me. I'm Dr. Siddharth from Mumbai. So today we have with us Dr. Babita Ghai ma'am. She's done her MBBS, MD, DNB, FAMS, Commonwealth Fellowship from London, a lot of qualifications. She's professor and consultant in Incharge Pain Clinic, Department of Anesthesia, PGI, Chandigarh. And she's got a lot of international executive positions. She's co-chair of the Developing Country Working Group, a member of ISP Presidential Task Force of Interdisciplinary Pain Treatment. She's treasurer of the Pain Education SIG of the IASP. She's also the editor for Acute Pain SIG, that is Special Interest Group of the IASP. She is holding a lot of national executive positions like the Special Board Member in Discipline of Pain Medicine for DNB, the secondary DNB, FNB for National Board of Examination in Medical Science. She's got a lot of awards. Some of them include ISA Presidential Award for Academic Excellence, Excellence in Pain Research by WIP India, Fellow of National Academy of Medical Sciences. She's also been a TEDx speaker and got the COPS Award as well. She's got around 150 index publication and several national and international book chapters as well. So welcome, ma'am.
Thank you, Siddharth. Thank you. First of all, my congratulations to continue conducting this academic activity. And I must applaud you that despite busy, private schedule, you are still continuing it.
Thank you, ma'am. Over to the second distinguished faculty whom we have with us today. So he's Professor Dr. Sandeep Sahu, sir. He's done his MD, DNB, PDCC, MAMS, FICCM, FACEE. Some of the abbreviations I will not know, sir. Please excuse me, but a very decorated gentleman. He's a professor, Department of Anesthesiology and Intensive Care at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, in India. His area of interest includes transplant anesthesia and critical care, emergency and trauma. His important appointments include the Secretary for ISA UP State Chapter, past President of ISA Lucknow Chapter. He is the international instructor for ACLS, ATLS, FCCS, trans-esophageal echocardiography, POCUS, and airway courses. He's got numerous awards, some of them being KPR Young Anesthesiologist Award of ISA 2014, YG Bhojraj of ISA 2015, Presidential Appreciation Award 2021, INDUSEM International Award 2014, ICN National Award, IMA Appreciation Award. Sir, there is huge list. Please excuse me if I miss any of these. So he's got an academic experience of more than 18 years of teaching and research, 90 publications including 20 book chapters, and he's got more than 400 lectures delivered already. So welcome, sir. Welcome to our journal club for the first time. I have had the pleasure of working with you when I was a senior resident, so it's a pleasure welcoming you here. Sandeep, sir, are you here? I think yes. Request you to unmute. Okay, so I think we can begin our discussion till we sort out the mic issue with Sandeep, sir. I'll just help him out. Ma'am, you can just start the discussion with both the papers. Any questions? I will just search from the chat history and I'll just point it out to all of you.
Thank you, Siddharth. Thank you for your kind introduction, first of all, and again inviting me to this journal club. Akhil and Neel, the question is to both of you. When you present articles in the journal club, and when you critically analyze, so how do you say that what exactly should be critically analyzed in these articles? So first, Akhil, what is there in your article which you can think of, not just a positive point, but let's see is there any thing which you feel a flaw, not exactly a flaw, a type of article or whatever it is?
Ma'am, the article covered the MSK conditions very nicely, which were being discussed with how the patients present in the emergency department regarding only the musculoskeletal ultrasound findings. That being said, they did not discuss they discussed only the diagnostic part. They did not discuss the interventional part. But considering the authors, all of the authors were from the radio diagnosis background, from the Department of Diagnosis and Imaging. So I think that is the reason that they did not go for the interventional part. They just mentioned that, and they did not consider putting that as a analysis-worthy thing to be done. And that is something which was because the title of the article is musculoskeletal ultrasound in the emergency department. If you are diagnosing something very nicely, why not for example, if it is an abscess, why not just aspirate the abscess and at least send it for a biopsy immediately and make a diagnosis?
See, we really do not know whether what they have done. So according to you, this is a beautifully written article where they had tried to cover, and it is just that they mentioned only about the diagnostic part. They did not have any intervention done. Okay. What about you, Neel? How do you critically analyze your paper?
I also feel the same, man. This paper was also about spot diagnosis, and it was also done in the radiology department, which was done in the Greece in their setting. So they have chosen, I think, the cases that which they see more commonly. They have chosen the 16 cases out of those, and they have presented just the radiographic findings along with the history.
Okay. So if we talk about here, and we discussed what is like you really critically analyze in journal club is the quality of paper, the methodology, maybe a Pico format. So both these both these manuscripts are more of a narrative review. Okay, this was something they noticed, and then they presented it and put in the manuscript. So this is more, both the articles are from the point of learning, a very good article, where it's more like a seminar. It's more like where the authors wanted to pass across to you that lot of things can be done by the ultrasound with good sensitivity as well as the specificity if you are involved there. However, when we talk about any other article, say we would have taken a type of articles. If we talk about ourselves, publishing, maybe the radiologists have still the scope of publishing the narrative reviews. We as an pain physicians find it extremely difficult to, publish just a narrative review. You can either have a systematic and in the secondary research. This is not a primary. This is in fact not a research. What they did, they collected the data and they presented it to you, okay, and presented it to the house. So this is not even a secondary research. So we are not talking about primary research. There are many. This is not even a secondary research. So we have to keep it in mind that about the article. So if we keep that in mind, that this is more of a narrative review. If you give write in current scenario, you send narrative review to good journal, they would come back to you and they would say that we need either the systemic a systematic review, or we need meta-analysis. Narrative reviews in current scenario are very, very difficult. So forget about that. The quality. So this is one thing which all the houses should know. When we come to the journal club, we discuss about most of the time RCTs or interventional studies, and we try to find out how the authors have done their methodology, whether it is a strong methodology, whether we should have done something different, whether their results were different. But yes, having said that, this is a very, very informative. Both the articles are very informative. Very informative. Now, what is that? If I ask the question to whole of the audience, if they can put it in the chat box, that what is that you gain from these articles?
So, Dr. Babita, good evening, ma'am. It's Sandeep Sahu from
Sandeep.
Lucknow.
In fact, we were waiting for you.
Yeah, I am there. I am listening.
Yes,
I am
good
listening you that you are already fulfilling the task to be done by me. You are already a mentor, and so you have already described that what a journal club and what is our expectation, and how we should narrate or analyze the article. So both the article presented very well, and I will say I must congratulate the presenters, both the presenters. They have worked hard, and what we learned that although we do a lot, but we publish less, I will say. So both the work that is published by the ultrasound MSK in emergency medicine is growing day and day, and even in India, the people in emergency are using this for the management, for diagnostic, and both the therapeutic purposes, because our setting is slightly different, I will say, from the Western world, where they may have limitation for the diagnostic, but here we have the pressure to treat also. So either intervention radiologist taught us how to aspirate in chronic settings like ascites or any collection or abscess drainage that we learned from reading or teaching it with each other. And simultaneously, I will say that in SGPGI, one good thing is that we have common clinics with the radiologist, where anybody can come, especially the team that doing work in that setting is welcomed, and they discussed, and with time we have learned with them, and now the ultrasound we are using in acute and chronic both the setting, and both the article says that we are doing similar work here, either in acute pain or chronic pain and emergency department. And besides diagnostic, we also do the therapeutic part mostly. And whether we are going for monitor anesthesia care to provide the procedures in the radiology suites, sometimes we also have to go for like MRI, CT with the intervention place, like where this ultrasound guided FNAC and this type work is going on. And with time, we learned that what we do in our OTs, we are doing in similar way that they do, and we are used to have this type of diagnostic work and therapeutic work whenever possible in emergency department. And in India, last 10 years, we are learning and growing together. So it's not a big task, but definitely the MSK is coming a big way, whether it's training or teaching. Even for the radiologist, I know that boss is in radiology department in Chandigarh PGI, and I met the chance to meet both of you. And with time of learning and validation with the expert from somebody from radiology team, we can do wonders in emergency setting. And chronic pain, ma'am, you are already working, and you are already the masters of doing pain work in chronic pain. In acute pain also, that the MSK is much more needed, and it needed a certified training. Even radiologist has to undergo fellowship for the MSK, and I will say that with this learning with them, or doing some short-time fellowships, we can learn with this science of MSK and help our patients. Thank you.
I think, ma'am, we have some responses. You can just discuss. You already have typed the answer, but you can just discuss that.
Thank you, Dr. Sahu, for your explicit explanation and information. One thing is definitely there. I see I had asked that what do they gain from the article? One of them, Dr. Ahmed, has said the scope of pain physician in emergency medicine is something new where I come from. So may I ask you, Dr. Ahmed, where do you come from?
It's
And
from
I
Africa.
have replied to it that most of us, the scenario is the same. We as pain physician are being, more towards chronic pain, and
So that was the purpose of me taking up this article, because you need to increase your understanding, increase your roles, rather than contesting the roles of fellow physicians, where already many people are there. You are also saying, okay, I am also here. You can create a blue ocean strategy, wherein you can add to the existing science and be the pioneers in that particular field. And I feel we are very fortunate today that we have mentors from two PGIs who are expert in doing all this and leading the way for the rest of the country. So, ma'am, over to you.
Siddharth, this is what. So Neel and Akhil, both of you are still not coming up with the answer of that. What have you gained more, maximum, and out of these articles? So, Akhil, maybe a short answer.
Yes, ma'am. So, ma'am, very rightly said by you earlier also that there was no meta-analysis or even an RPT. So when we had decided on the theme and we started choosing articles for this, and there is no meta-analysis on musculoskeletal ultrasound diagnosis in the emergency department. You will have various musculoskeletal diagnosis for various separate modalities, but not for an entire umbrella category. Again, interventional, definitely not in the emergency department. There is no meta-analysis on it. Even there is no randomized clinical trial on an umbrella category where you have all of the musculoskeletal conditions being discussed. And most of the diagnoses have been published as a review article maybe, or a narrative review, which was the best chosen ones were presented. And what I learned from this was that all of these conditions which we are already seeing mostly on a chronic scale, and they can be very well be dealt on a acute scale also when the patient presents acutely with such conditions in the emergency department. The only reason is we maybe are not that available in the emergency department as an interventional pain physician, and we are usually available in the OPDs or the operation theaters where we are doing a procedure. And if the emergency department has a code, or when they can actually need us, they might call us. That is when you can actually say that we do have a role there, but that is when they actually need to call us. Like you call a code team or you run a code, then.
So you see that as a chronic pain or a pain physician, you might have a code team to call you. Okay, well, I'll just sum up pros and cons of that. Neel, what do you say? What is to be gained? Or Akhil, if you have anything like any con for these articles, not pro, for this article, again, before you can think of it, by the time Neel is answering. Neel?
Yes, ma'am. Although it was a type of a narrative article, but what narration they have given, it must take a great deal of expertise to come to such diagnosis, means spot diagnosis. So we'll have to develop the similar level of skill as the radiologists have. So we will be fluent in these conditions and we would be able to diagnose it on the spot. So it will have definitely have a learning curve.
Very good. So this is one thing which came to my mind, and this is what we should also realize, that the role of finding the, to detect the MSK pathologies, acute pathologies, we really need lot of learning. And we must most of the chronic pathologies we are able to detect. We see a bursal thickening, we see a tear, we see a full thickness tear, we see the partial tear. But when it comes to diagnosing in the acute scenario, we really still need lot of learning. And now the scenario comes with the competition. Now we are competing with two major specialty. One is the emergency care specialty, wherein they are actually have a curriculum. They have a curriculum of MSK ultrasound in the acute setting. Okay. And another thing is that there is a fellowship in radiology, which is MSK fellowship, which is also run in PGI. So we, before, take a message to chronic conditions, we are well versed with, and we are doing what is happening that MSK fellows are not doing ultrasound too much for the chronic scenarios. So it is a modality of learning. Okay, जो ज़्यादा करता है वो ज़्यादा सीख जाता है. So if we are doing more, we are learning more than we are much better than radiologists in diagnosing the chronic conditions. However, when it comes to acute phase, then they are doing lot of they have lot of learning. They are very before we structured fellowship.
Ma'am,
wherein
we
we have
lost
learned this.
last few lines. Ma'am, can you
One
repeat
thing.
the last two lines?
So I'm saying that before we jump on to the involvement into acute setting and going role of ultrasound, we must also have a good training. That much training which we already have the experience of chronic pain, similar experience should be there in the acute setting, which many of us might not get a chance. So our role into acute setting is still questionable, but we cannot totally evade it. As I answered to Dr. Ahmed, we've already been exposed to the emergency settings during the anesthesiologist posting. So this is one thing, but yes, lot of MSK is still coming up, and I'll just share my experience because I am lucky to have my MSK ultrasound OT for last 1.5 years only. We now have an isolated ultrasound OT where we post only ultrasound. So the more we see, the more we learn, and the more cases we get. So I can share few of my experience. We are getting a patient, this is a recent one. I have not yet posted it to any of the media. A 16-year-old patient who has been referred to us with a distal sole, half of the sole, bilateral sole, burning sensation and severe pain and allodynia for last 2 years. And he's walking throughout for last 2 years on the heel. Okay. So what do you think we could do? And he has been on, let me tell you what he is on. He is on lamotrigine, maximum doses, gabapentin, maximum doses, already going on duloxetine, maximum doses, amitriptyline, maximum doses, and there is fifth drug, which is also oxycarbamazepine, 300 BT. So he has got no relief. Now, if we would have really been picked up early during this scenario, then we would have been able to give this person some good intervention. So Akhil and Akhil, what do you think we could do this, and how?
Ma'am, we
So
would need more
burning.
history, ma'am. Was the patient having any history of injury before this?
History of?
Any history of injury in bilateral limbs?
No. And history of similar symptoms 10 years back to her, 10 years, 6 years back in the family, sister was diagnosed with a similar pain, and they lost the child at the age of 15 years. Now they are very scared. So history of trauma is not there. Pediatrics say this patient has been referred from pediatric medicine for nearly 1 year. He is visiting the pediatric medicine OPD, and they have thoroughly investigated.
Okay. Any scans which have been done?
Everything. So you keep asking me, I'm going to tell you, everything is negative. Everything is negative except on NCD. They picked up small fiber neuropathy. That's it. Diabetes not there, hypertension not there, echo normal, any scan is normal. But this is, I do have videos of. So what will you do? So you evaluated, you're trying to find out the cause. Everything is normal except for few genetic studies, which are also not negative, and few genetic studies are still awaited. Everything you ask me, I'll give on, keep on giving. So you have evaluated the patient. Nothing is positive except for the diagnosis of small fiber neuropathy. There is no vesicle, there is, and taken from the skin up when the patient is come to you and refer to you for the management. What will you do? Anyone of the house, anyone. Here comes the role of ultrasound. In extremely
ultrasound MSK of the plantar fascia and the retrocalcaneal bursa.
no, there is no thickening,
Negative.
there is no calcified. Huh? So negative. We have done that.
Okay. Any pathology in the lumbar spine radiating to the lower leg?
No. There is no radicular component. It is not even the full sole. It is half of the sole, distal half of the sole towards the toes.
Okay. Any impingement in the maneuvers, inversion or eversion of the foot?
No.
Okay. Weight bearing is painful, or the pain is even on non-bearing condition?
Non-bearing condition and weight bearing increases it. So he has allodynia also. He hardly wears any slipper. He has made a special slipper which is not going to touch his distal portion.
And it is equal in all of the 5 toes?
Equal in all of the 5 toes.
Morton's neuroma would be unilateral mostly.
Nahi
hai. And you're saying small fiber neuropathy? Any autoimmune condition which was ruled out?
No. तो अब पेशेंट आया है आपके पास, अब आपने क्या करना है? But you are just thinking, मैंने बता दिया उन्हें, you are thinking in terms of only diagnosing.
Yeah.
So move further. So this all were required. I did check up. So the role comes for the diagnosis. So I did check up the Achilles tendon. I did check up the ankle ultrasonography. There was no calcified ligament. There was no compressive. So how's his hearing? Whatever he is asking, there are few of the things where the ultrasound is come for the role of diagnosis. So everything is negative. I did. Morton's neuroma. What exactly is Morton's neuroma? I do not know, but there was no neuroma.
Ma'am, it's like a neuroma in the presence of a neural ganglion or a neural cyst between the second and the third toe.
So, chale hum accept kar le that we have accepted that this patient is a small fiber neuropathy. We do not know why, but there is some family history also. So agree. What next now? Neel, what next?
EMG was insignificant.
EMG was
fiber
there was EMG.
That was NCV. EMG was insignificant. NCV showed small fiber neuropathy.
It was skin biopsy as well as the NCV.
Okay. Any systemic cause? Any blood reports which are ruled out?
All negative. dsDNA, ANA, RA factor, everything was evaluated.
So what, ma'am, we have done any intervention to relieve pain or?
Dr. Sahu ne see, we are just, yes. So what we did, this is what I wanted to ask. What, yeah, आपके clinic में बैठा है. The patient is standing or sitting in front of you. What will you do?
The last thing which would come to your mind would be a CRPS, I think. The last thing which would come to your mind would be CRPS, complex regional pain syndrome. But again, for that also you would need a inciting injury. You cannot just come to a diagnosis.
What are you going to do? See, you have evaluated, taken 1 hour of examination, everything, purane records. Now what will you do? Dr. Sahu is asking, what have you done?
A diagnostic lumbar sympathetic intervention can be done.
Okay, now listen, why and how my thinking changed, because I've been doing MSK OT, ultrasound OT for last full 1 year. So we thought of giving, first of all, we tried to find out, obviously, what is the nerve supply of this area? So
the lower part.
it is, even we had to go back, but we can no. So it's a medial and lateral plantar nerve, and it is, which is the branch of the posterior tibial. So
medial
Dr.
lateral
Sahu-
plantar from the posterior tibial.
Unless if you are targeting the digital cleft, which is deep peroneal nerve, you will have the first
Yes.
that cleft area which is supplied by the deep peroneal nerve.
Sole area,
Yes.
still sole, which is medial and lateral plantar. Ideally, the sole area being covered by the medial and plantar, the complete sole area.
But ma'am, where is the pain? Pain is in the
So-
anterior half, right?
Pain is in the
Yes.
sole area.
Sole
Sole,
area.
dorsal.
Anterior dorsal.
No, it's नीचे जो जमीन पे लगता है.
Ventral,
Sole.
not dorsal.
Sorry, ventral.
We call it.
So, ma'am, on an MSK, you could see impingement of the tarsal tunnel.
Not there.
Not there.
So what we did, we
So
gave
you
him
can do a tibial nerve block and see whether it helps.
yes. So because he's been already on 5 medication, full doses, and he's not getting relief. Not slept in last 5 months, more than 3 hours a night. So we gave him nothing else. Simple. We gave him a posterior tibial nerve block using steroid and bupivacaine. I used bupivacaine higher concentration, 0.5%, but it was an ultrasound guided posterior tibial nerve block. And immediate relief. Today is the 18th day of after the block. He is 95% pain relieved, but still some pain is left in the tips of the toe. That's it, to all the toes.
Ma'am, the allodynia went.
It's gone.
And what did you give in the block with lignocaine?
Nothing. I'm telling you,
Bupivacaine.
0.5% bupivacaine and
No steroid.
and
Steroid.
steroid, 20 milligram of steroid, nothing
And
else.
20 millimeter. Okay.
So the house agrees that when it comes to chronic pain condition, lot of pathologies are involved, and once you break the cycle, it might get relieved. But role of ultrasound. So we have now created a series of our own. We have given lot of common peroneal, 3 patients, common peroneal nerve. Okay, again explanation. There is this lady from Manipur who has had a fracture. Ghar mein gir gayi. She is a businesswoman. She is 36-year-old, and she developed fracture of the lower limb, and she had a rod placed in the tibia, screws. And since 2 years, she's been having severe pain, scar neuralgia at the screw level. And whenever you touch that screw ka niche wala area, you will get a allodenic pain in the lateral aspect of the calf, anterolateral aspect of calf till the lateral malleolus. So we gave this patient again. We thought of giving initially the diagnostic block, along which becomes therapeutic because we are adding steroid, and then we would just always think of getting these patients back in and do PRF or CRF depending on the type of nerves involved, because we have only 2. Cryo can be done for peripheral nerve. These are the patients who might be in long run, might be for peripheral neurostimulation, but again we are not going there. So common peroneal nerve block would be given. All steroids. Also chronic pain may we have the role, but now in acute pain may, if we also know lot of regional sonoanatomy, regional neural and MSK sonoanatomy, we do have a role there. Over to you, Dr. Sahu.
Yeah, ma'am, it's definitely, as you mentioned, definitely ultrasound was domain for somebody. And it's not the fight, I will say, because being a pain physician or anesthetist for managing acute pain in OR only, because our work is limited there. We are not available in emergency in odd hours. So definitely we have learned this science from the radiologist, and they are all happy because this sharing and learning going on, because they have more, like in our institute, they are more in intervention. We have to request, especially with faculty, because they are very busy, less faculty. I will not say they are busy from morning to nights, either MR or the intervention. And we have to request whenever we have any personal ultrasound, and they do come to help us. And mostly residents are busy, or the fellow is busy doing the ultrasound. When we say that they have to come to us for chronic pain or to help us, or in our emergency department, because I am lucky to have worked 5 years in emergency department to establish emergency medicine in SGPGI. uh, because uh, in emergency, the trauma patient or pain patient with pain are the frequent visitor, and they are uh, only thing, same ultrasound, three places ultrasound in OT, or in pain clinic, in emergency, or it's in for only diagnosis was in radiology. But same thing, only thing that in where you have to prove early is for acute pain, because patient trauma patients, and in trauma patient, if we see the initial assessment, the primary survey, the pain is the part of ABCD management, and where as soon as you stabilize the ABC, then comes the role that patient should be get its patient right to give pain relief. And here the MSK with peripheral nerve block are doing wonders, whether it's a fracture femur or the chest pathologies like flail chest, because patient will not come out from ventilator. It can be more problem from because the pulmonary contusion leading to ARDS and prolong stay on ventilator, and then ventilator associated problem comes there. And giving analgesic from I will say from IV route or from other route is not, they have systemic effects. And here the role of because they say they see to us in same way that we see to radiologists to for help. So initially for learning, uh, we get together. It's for sharing, and uh, there is need that they want the pain management and peripheral nerve block. We are already giving, whether it's it for anesthesia or for chronic pain, but it really works well, because nowadays in our trauma center, uh, it's part of ED. Now patients are given block in the ED, whether it's a musculoskeletal trauma, and I will say the polytrauma is very less patients in India. The mostly it's musculoskeletal trauma. It's part of orthotrauma or head injury assured with the musculoskeletal trauma. So definitely need is there. We can do combined studies, we can publish together, because the patient are different from control setting to the trauma setting, or in emergency when they are coming with any foreign body, like penetrating injuries or any foreign body. Usually even kids, they insert something, and they have pain, and besides giving systemic uh, analgesics, this our local field block, even for removal of foreign body, the anesthesia we are giving less nowadays, either field block or muscular block, with help of ultrasound. So it's changed a lot. Even I will say in reconstructive surgeries, I have learned this science, that our plastic surgeons, they are very good in giving blocks. And when I was resident, they said, don't give GA. You were just give monitor anesthesia care, and or you please give block. So I will say that is reconstruction part, uh, during trauma management or after like definitive surgeries, because they have to undergo multiple surgeries multiple times. And this the use of ultrasound for musculoskeletal uh, pathologies, for pain management, and even for its very good. I will say I am one of the I'm a diabetic patient, and I have the frozen shoulder, and it's really changed when I was given one pericapsular infiltration, and it changed my physiotherapy. So I itself one of the beneficiaries, and whenever it's rewarding in emergency setting. And definitely we have to hand holding to our emergency physician, or like trauma surgeon, those who want to learn this. And because we can't be there every time. So my say is that it's not stealing or dominancy of uh, each other on each other. It's mutual learning. We can teach, keep the teaching together. Even we can send our pain fellow in emergency setting or our anesthesia fellow in emergency setting for a rotation short 15 days or 1 month, if whatever is possible, so that they get the confidence in doing work in that setting as compared to a control setting. Because in chronic pain we always have a plan thing, and we work up and our I will say our protocols in our department for chronic pain. Our team is doing very good. I am not part of that, but I am very impressed with their work, doing of work. They do all the protocols, all the safety protocol, even monitoring, giving sedation, analgesia, even for small procedures, and making patient pain free for relieving pain. It's very good. So this is what my observation for MSK utility in emergency setting, I will say. So have you got the chance, the Dr. Akhil or Neel, that have, because it's not different. It's only the setting is different. The environment is different. So I think if you have you get the chance, or if you got the chance, would you like to be part of team for acute pain management in emergency setting? This can be called from ICU also, because some patients also need your help. A polytrauma patient in ICU, and they are on ventilators or other therapies, and they need help from us.
Dr. Akhil, Dr. Neel, this is a question to you.
Yes, sir, definitely. Most definitely. It will be very helpful for the ED also, that when you get a call for acute pain control or management, if
No,
we are
I
available.
differ on this because if you are working as a chronic pain physician and you are available only 4 hours, 6 hours, 8 hours in a hospital, this call can come anytime, 24 hours. So the acute pain service, which is available 24/7. So I think this responsibility should primarily rest with the team. And of course, if they need your help, you can be a part of that team. But then you can come in the morning and do your your rounds during daytime, and then you can just go. Unless if you are there available, residing in campus, and
Siddharth,
24/7 you are available, and as soon as that CUG number rings, you are
this is a
there.
very sensitive talk and a very debatable talk. It depends also on to the institute to institute. Like in what we are about to start, happy to share one good news is that our pain fellowship is crossed another step. Staff council say it has been approved this Monday. But okay, before while we were making the curriculum, one head said that you should also take up the APS. Another head said that you should be making the APS totally different.
Ma'am,
Okay.
I don't think it is even a debate. I'll tell you how
Start.
it comes. It is just
Same
an
here.
operational issue. If
Yes.
the adequate staff is provided,
Wait, wait,
very
wait.
like for example, if any,
Siddharth, wait.
yeah,
So I was very clear as what you said exactly. APS is altogether a very different scenario, and APS need lot of staffing. It needs manpower, it needs different infrastructure, it needs clerical staffing, it needs nursing, dedicated nursing staff, it needs pharmacist. Okay, so I told my seniors that if you provide me, this curriculum is made only for the chronic pain curriculum. If you want to include APS, I'm happy to have APS, provided you give me this much of infrastructure, this much of manpower, and this much of the things extra. And then they agreed. So, Dr. Sahu, given a chance, see, as a physician, what I feel, yahan pe in the acute setting, our role as a chronic pain physician, as a pain physician, which is considered actually a chronic scenario or a chronic pain scenario, role in acute setting will not be great. See, in acute setting, once you go to the trauma, you come to the trauma center of PGI, you would realize Actually, the pain should be given importance. Yes, pain is still in the lower. ABC is pretty high, and you get lot of ABC. And managing pain becomes a holistic component, but it is never a priority. Okay, so role of a pain physician in the acute setting would be very dicey until unless you have a whole APS team and a whole scenario of infrastructure. But what you can do, we can be called the way Neel or Akhil said something. Somebody said that there should be a code. Yes. And most of the time, acute scenario, the acute emergency physicians are able to manage whether it is acute pain or whether it is acute hemodynamic protuberances or whether it is acute respiratory protuberances. In some scenarios where they are not able to manage pain, they can call us. We might add on to that. But keep it in mind, we are talking about MSK. We are very good at neural finding. MSK, we are also trained in chronic scenario. In fact, getting the MSK acute scenario, you still need lot of training. You would be only called if you are expert in that area. So what do? They usually call, obviously, we have MSK fellowship and we have increased it from 1 year to 2 years. So we have very, very trained MSK, even MSK radiologists or MSK fellows are very trained. So whenever they get stuck up for any situation, they do call orthopedician. If they get stuck up, plastic surgeon gets stuck up, emergency medicine gets stuck up, they do call MSK fellows. But we still have an upper hand. If I speak to my MSK fellow here, their experience in finding the nerve is not great, which is much easier than MSK. So we do have experience there. So if you are working in a setup where you are providing services like me, I'm providing services both at acute area 50%, in chronic area 50%. You would be working. Otherwise, once you are working as a pain physician, your role in acute setting is not, I don't see the future is going to be too much involved. As Siddharth said, we have so much in our plate. We have to manage so many other things that we cannot get into acute setting. Acute setting is very demanding as far as the infrastructure and the manpower goes.
I totally agree with you, ma'am. Even in my hospital, either we are busy in the OPD seeing patients, or on alternate days we are doing OT, and it is a very hectic schedule. So, as earlier was also being discussed, like if there is a code, maybe you need our help for some special MSK diagnosis case or 1 or 2 cases, we will be available. That also depends on our availability. But if not, then definitely we are very good at diagnosing impingements, and something which the radiologist also is not that good at, because they usually do static scans, they don't do dynamic scans.
Yes.
So my radiologists have started calling me for impingement scans.
Good.
And so over time I think it changes, but I think it is a collaborative effort. You cannot just win a war alone. You'll have to deal with a patient with a collaborative effort. You're a radiologist, a plastic surgeon, a neurosurgeon, maybe you'll have to talk to each one of them personally, maybe for a case, especially if it is getting difficult. Like you talked about a case which was difficult. I think the more people you get involved, the more minds are working on the same thing. You might get to a diagnosis sooner. And I think that is a part which is very different to a institution.
Yeah, I agree, ma'am. I agree with Akhil and you also in a setting, because the things are different, ma'am. There are, I will say, 4 types of place we are working in institutes. We have our own boundaries, limitation, no or yes. But when any new anesthetist who has been trained in pain and goes out and he want to survive only on pain, and we know that it's a big issue to survive him in periphery, but he can show us a spectrum that I can be of utility here also, because as in PGI Chandigarh, the trauma anesthesia is, because they are also our colleague, and they definitely, we can't work everywhere, we have to work in one place. So some our fellow working as a trauma anesthetist, and because they are always available on the floor,
Yes.
in their ORs, and they can have their extend wing to ED, because my boss is always telling me, आपको मरना पड़ेगा तभी आपको स्वर्ग मिलेगा. So I am quoting Professor PK Singh साहब कि जितनी जगह करके दिखाओगे या लोगों को अपनी इतनी आदत डाल दो कि आप ना वाले एनेस्थेटिस्ट से इतने हाँ वाले बन जाओ, या इतने पेन फिजिशियन की आपकी यूटिलिटी वो मतलब तो डेफिनेटली भाई हमको करके तो दिखाना पड़ेगा अपनी ईज से निकल के। आपने सही कहा कि मुझे लॉजिस्टिक जैसे इंस्टीट्यूट में वर्क करूंगा, तो जब ये लोग फैकल्टी बनेंगे, ये लोग प्रोफेसर बनेंगे, तो इनको अपना वो से भी रखना है कि मुझे नर्सेस चाहिए, मुझे उनको ट्रेन करना पड़ेगा ताकि मैं एक्यूट पेन सर्विस अच्छी चलाऊं। मुझे अपना रेजिडेंट चाहिए जो राउंड लगाएगा, और लॉजिस्टिक मुझे इक्विपमेंट भी चाहिए वहां पे, उसके लिए अलग से इक्विपमेंट चाहिए, अलग से स्पेस चाहिए। अगर मुझे मान लो माइनर ओटी वहां पे मुझे प्रोसीजर करने के लिए चाहिए, तो डेफिनेटली दिस इज वन डिमांड कि जब उनको वो चीज करनी होगी। और डेफिनेटली कोलेबोरेटिव भी है कि जब आप दिखाते हो कि आई कैन ऑल्सो डू और आई कैन ऑल्सो बी यूजफुल हेयर, तो मेरा बस इतना कहना था कि वो अपनी यूटिलिटी दिखा सकता है।
बाकी सर, बाकी यह है कि फॉर द हाउस वी शुड, डॉक्टर साहू, यह है कि फॉर द हाउस आई वांट टू टेल दैट व्हाई डिड आई यूज द वर्ड competing is क्योंकि in my husband is a radiologist, he is into pediatric radiology, so thankfully we do not have conflict of interests, okay? So rather than just the conflict of interest of normal husband and wife, point is that Radiologist Association IRIA has
I think, ma'am, I'm sorry to interrupt. We are exceeding the time by around 20 minutes now. So I will, take the liberty to just cut short this discussion. Before we end, I give Dr. Babita and Dr. Sahu there, if they want to say
Uh,
anything, just 1 or 2
I
minutes. Please
think,
summarize the thing.
yeah, Siddharth, we have already said our part, and it's better to conclude because people get bored if we continue discussing. So they should get the benefit of attending this
tell
session.
that everybody
Yeah.
must be waiting for food. Dinner नहीं खाया है किसी ने, मैंने भी नहीं खाया है.
मैम कुछ लोग होंगे जिन्होंने बनाया भी नहीं है. So let's
Okay,
let's
just before one thing, next time when you come to the journal club, any one of you, I hope, Siddharth, we are doing the critical analysis using the CLAPS tool. Any tool
I
we are
think, ma'am,
using?
we can have, if you allow, and I'll take the liberty to, request you. We can have a small talk from you on this, and then how to read and analyze a paper. You had last time taken some basic things, and that was quite enjoyed by many of us. So maybe I can take the
So
liberty
how
of
to go about,
having.
okay, how to critically analyze a paper? How to critically I
Yes.
took one example of neuromodulation, if I remember.
Yes, yes. So I
It's my
think
question.
we will, because it will be very helpful for all of us,
So,
because nobody's using the criteria on how to actually follow all these steps, because human mind
okay,
is fickle, and if we don't follow a framework, we tend to forget the things which might be very
okay.
important.
Siddharth, I'll just also cut short it. We will in some future. I'll how to choose an article. Number one, for journal, what exactly is the purpose of journal club? Why was the journal club made? I will talk about that. How to choose an
That'll be
article,
great, ma'am.
how to present, and how to critically analyze. These four things I'll talk
Great,
about.
ma'am.
So
Great.
maybe I'll do that.
So, Dr.
Because
Akhil, Dr. Neel, if you want to say anything, please say it now.
sorry, एक minute. Because in chronic pain also huge, you have such wonderful, beautiful articles written where you can still find the critical analysis.
That's correct, ma'am. Dr. Akhil, Dr.
Yeah.
Neel, if you want, you can just add a few things before we end.
I
I
must,
think it was a very
first of all, a big applause for them. They have, both of them have presented so well.
Great.
thank you, ma'am. And
Yeah,
I
many
Thank you, ma'am.
congratulations. Many congratulations to our future leaders and the presenters. Thank you.
thank you, sir.
Thank you, sir.
I feel it was a very comprehensive discussion as well, and I think it
So
was
this
well
was,
delineated.
yeah,
The,
so
I think the task of a chronic pain physician and an acute pain services was well delineated, and it is required, I think, because when you're working in a clinical scenario, you need that differentiation properly, because people maybe don't understand the requirement of a chronic pain scale, the amount of patients we are seeing, and the amount of work which is being done in chronic pain alone. It is very hectic to even do it on a daily basis. So I think that differentiation is very important. And acute pain services is a totally different ballgame, and it comes with its own backlog. So it should be kept quite separate than chronic pain. Chronic pain should be dealt as another department entirely. I think over the years it will change definitely. But all in all, a very wonderful discussion over MSK, whether in the ED or even other diagnostic criteria. MSK ultrasound is the need of the hour. Thank you so much, ma'am. Thank you so much, sir.
Dr. Neel, anything from you?
No, it was a great discussion, sir. Thank you to the both faculties.
Okay, great. So before we end, special thanks to Babita Ghai ma'am and Dr. Sandeep Sahu sir, as well as both the speakers. So we'll end the discussion now. This is the season 4 of the Mumbai Pain Schools Pain Journal Club, and this season we are focusing on MSK ultrasound. This season we had a new time, that is 8 p.m. We had group topic for different seasons. So this season we had this MSK ultrasound. We had a format of 2 faculty, 2 papers. We discussed always the paper in advance. The next step for you guys is to just join our mailing list, and we have a WhatsApp group which we have posted link in the chat and email. Any suggestions, comments are most welcome to be sent to us on mumbaiPainSchool@gmail.com. And next journal club is not on the next Friday. Next Friday we are busy for a conference, so we will meet on February 2. That is the next Friday at 8 p.m. for the next journal club. And of course, I will discuss with Babita ma'am, and at her convenience, we'll post one special session for this, because the last time also she taught us. Those of you who want to just search, go down the Mumbai school page, and you'll find a recording to that as well. And she taught us extremely nicely, which I think we should adopt as a template for future critical analysis, for the future discussions. So Akhil, I think you can find that one and share the link in the group. That will be great help. We'll have our next hands-on workshop in April, 26th to 28th April. So those of you who are planning to attend, please block these dates and welcome for Mumbai. With these words, I thank you all very much for attending the session today, and we end the journal club.